Good afternoon, everyone, and welcome. My name is Elliot Williams, and I'm the training coordinator at the National Press Club Journalism Institute. Thank you for joining us. A few things to note before we begin. We are recording this program. Highlights will appear on our website and in our daily newsletter for journalists, the latest, which you can subscribe to using the link in the chat. Feel free to submit questions using the chat or Q&A feature. Your questions will be addressed at the end of the program, and let us know where you're tuning in from. Solutions-oriented journalism about America's public health landscape has become increasingly important as disinformation continues to spread and health disparities widen among marginalized communities. With that in mind, we've launched this series of virtual programs for journalists who cover public health. In today's discussion, we'll learn about the complex but vital infrastructures and resources that make up the public health system. This program is part of the Institute's Public Health Reporting Fellowship, which is funded by the Common Health Coalition, a network that brings together leading health organizations in pursuit of a reimagined health system in which the nation's healthcare and public health systems work hand in hand. I'm joined by Dr. Rishi Manchanda, who is the founder and CEO of HealthBegins. Dr. Manchanda has championed bold strategies to advance health equity for historically marginalized patients and communities throughout his career as a physician, executive, and public health professional. He served as the founding director of social medicine for a network of community health centers in South Central LA, as the first lead primary care physician for homeless veterans at the Greater Los Angeles VA, and as the inaugural chief medical officer for a self-insured employer with a large rural agricultural workforce. In his book, The Upstream Doctors, and accompanying TED Talk, he introduced the concept of upstreamists, which I'll let him explain. Dr. Manchanda, thank you so much for being here and for sharing your time and expertise. I will drop off screen and let you have the floor.
Elliot, thank you so much. And everybody, it's great to join you today. I'm going to share a screen here and jump in with some comments here, but mostly I'm hoping to put something on the table that allows us to engage in a dialogue together shortly. So I think I'll speak for about 20 or 30 minutes, maybe at most, and you can rein me in, Elliot, if need be, so that we can get some dialogue going. At any point, if there are any questions, please feel free to put them in the chat as well. So let me go ahead and just share screen here to start my comments here. Can you guys see my screen okay?
Looks good.
Great. So as Elliot mentioned, I'm a primary care and public health trained physician. I really got into the field of healthcare inspired by folks like Paul Farmer, who is a co-founder for Partners in Health and a mentor of mine. And many others who exposed me to the field of what's known as social medicine, which has been around for about 200 years and represents a tradition in Western medicine that is squarely interested in two parallel questions. One is, how can we optimize and provide the best standard of care to everybody? And how can we do so while addressing the social conditions that put people in harm's way? HealthBegins really is the work I've been doing for the past 8 years full-time with my team. But my entire career has been shaped by those two kind of core questions, and the privilege of being a clinician and being an administrator and executive at different healthcare settings. And found that the way to be able to answer those questions is, of course, thinking about how healthcare can play a role to reinsert itself into a broader public health agenda. The work at HealthBegins specifically is to do what you see on the screen here, which is over the past 8 years, we have been working across the country with Medicaid serving health plans, health systems, nonprofit health systems, as well as community health centers, and CBOs, meaning community-based organizations or community-based nonprofits that provide social services to be able to exceed the growing requirements in healthcare, to exceed healthcare equity and social needs kind of requirements, and also to then resituate healthcare, the pursuit of health equity, and the desire to address health-related social needs for patients in a broader public health frame so that we can achieve longer term impact for people in communities, particularly those who are harmed by societal practices. We've had the privilege of working across the country, and I'm happy to share more about that work. But a lot of my my experience and my participation in the Common Health Coalition, which is a main partner and sponsor for this fellowship, comes from my work with HealthBegins. My understanding in the prep call that Elliot and I had for this is I was trying to understand what your goals are was what you see on the screen here. So if you see anything that is inaccurate, blame me because it's my note taking, not anybody else. But this is broadly what I understand to be the goals for this fellowship for each of you. First, through this experience, it's taking your foundational awareness and I'm sure deep expertise in covering healthcare or public health, but increasing that literacy about the distinction between the two sectors and also the relationship between them. The second is to help understand better public health policy as well as healthcare delivery. And what does that mean in terms of the stakeholders? Who's on the map in terms of how stakeholders relate to each other? And then finally, I think for each of the reporting projects you're all working on, some of which I was able to understand in my prep call and all sound phenomenal. It sounds like the goal for the fellowship is to help you identify more easily the kind of relevant sources of data, information, and analysis to be able to better understand public health policy or healthcare delivery and how it applies to your work. Broadly speaking, just to kind of do a kind of emoji check-in here, can you give me a thumbs up if I generally got this right, if I'm in the right room? Are these your goals?
That's right on the money. Thank you.
Good, good. So Beth and Amanda, that's great. This also just tells me who's paying attention. Awesome. So, just to set the stage a little bit, you guys have all seen, I think, various iterations on the theme, but kind of starting from a macro perspective, I wanted to pull up this report that came out this last year from our friends at the Commonwealth Fund, which is another really wonderful resource if you haven't come across the Commonwealth Fund. They've been around for decades and have been supporting, particularly in the healthcare space, and increasingly more towards the intersection of healthcare and public health, a lot of the research and a lot of the kind of philanthropic investments in being able to better understand and define healthcare and healthcare policy. One of the things that they did this last year was to put out a report called Mirror Mirror, which was a portrait of the US health system in comparison to 10 peer nations. And what you see here is, of course, the trend that I think many of you are familiar with, which is the increasing percentage of GDP that we're expending on healthcare dollars since 1980, when we were largely in alignment with other peer nations, including Germany and France and Netherlands and Canada and Sweden. But then how that since 1980 has continued to increase as a percentage of GDP to the point now where we are, approximately 1 in 5 of every dollar spent in the US and public dollar spent is spent on healthcare. And of course, the conundrum is that while we're spending way more per capita and as a percentage of our GDP on healthcare through public resources and Medicare and Medicaid, as well as through additional kind of subsidies and other payments directly to those in the commercial space that happen through kind of marketplace subsidies. While we're spending a lot more in healthcare in a variety of elements of our kind of deep industry in healthcare, we're not getting the outcomes that we need. Americans live the shortest lives, as this report highlights, and have the most avoidable deaths, right, compared to our peer countries. And so what the Mirror Mirror report is doing here is demonstrating that outcome using an axis of performance, right? Higher performing countries have fewer avoidable deaths and higher life expectancies compared to countries like the UK, Germany, and certainly the US as an outlier here that is lower performing compared to the average. So we are not getting the outcomes that we would hope, despite spending a lot more in healthcare. And of course, this is part of why I wanted to tee up this question to go to the first fellowship objective, to kind of double click on this a bit more and maybe provide a bit of what I would consider to be the 101 on these questions for your fellowship about public health versus healthcare versus medicine. This is a busy slide. I kind of orient you to, let's move from the left and then ping pong over to the right and then come into the table in the middle. So on the left here, there's some definitional components for healthcare delivery, which is really the provision of individual services, where care involves a relationship between a person who has a health problem and various care providers. The health system's key functions are to restore a state of non-illness, prevent the deterioration of health status. So if you're sick, how do we prevent you from getting sicker? And do that while preserving a person's autonomy. A lot of healthcare interventions are centered around maintaining health and therefore restoring the absence of disease if possible. Treatments tend to be curative, targeting individuals, and constitute diagnosis, treatment, rehab, palliative care. And most of the interventions, notably as you see in the bottom left, are performed in healthcare facilities. Public health, if you ping pong to the right here, as we know, is defined as the science and the art of, one way of defining this is the science and art of preventing disease, prolonging life, and promoting health through the organized efforts of society, which means collective efforts, oftentimes more than just collective efforts of what's happening within the healthcare industry or facilities, but including that and beyond, to be able to look at a variety of interventions and beyond just specific service delivery or specific programs. These are therefore broad interventions, involve prevention, promotion, and protection. And notably, it's really about decreasing risks, not just to be able to slow the progression of disease for somebody who's already sick, which is a similar kind of goal for healthcare, but to really focus in on the risk factors that are putting people in harm's way and helping to thereby slow progression of someone who already has a disease to worsening outcomes, or to prevent that person from having the disease in the first place. The approach really, it can target individuals and groups, particularly those that have risk factors. Obviously, it's a way to focus in on those who are at highest risk and those most in harm's way, but includes broad interventions that also are about those who are not necessarily at risk right now, but it's about health promotion. So this is public health is the ecological approach versus healthcare, which is traditionally a far more individualistic approach. So, I think these are hopefully very kind of common sense descriptions of it, but one that puts on one slide at least some of the ways in which we understand medicine and public health. The challenge is that unlike our peer countries, part of the reason that we have the poor outcomes, just to kind of go back to here, that we have, is in part because the relationship between public health and healthcare in the US, in my opinion, is broken, where these two pursuits right now have been decoupled, have been unmoored from kind of aligning around place. And I'll come back and talk more about that, hopefully in some dialogue with each of you, and also have been decoupled in a way that prevents, that is allowed for, I should say, the financialization of one sector, namely the healthcare sector, to now place increasingly the accumulation of profits and of kind of growth of an industry at odds with both the objectives of the industry itself, healthcare, as well as at odds with the goals of public health. And I can speak more about that as well. So in other words, this tension, these definitions are pretty straightforward, I hope. Hopefully this serves as a reference. But part of the reason that I think we're in the state we're in the US right now is in large part because of the fact that these definitions now in reality and practice in the US for the past 40, 50 years have seen the decoupling of healthcare and public health, and for a variety of reasons, that's leading to poor outcomes, less bang for the buck. And to kind of think about it this way, think about why we're having the kind of the poor outcomes we're having right now and what it means for the relationship between public health and healthcare. I pull up this kind of classic slide from kind of 101 health policy that I got when I was in medical school as well as in public health training. Being trained in both clinical medicine and public health, I found this to be a really helpful figure. This one is relevant to diabetes, but could be relevant to any particular condition. And what you can see here, starting from the smallest box, the cure and care provision, this is describing the different levels of the health continuum to be able to enable action on a given condition, in this case diabetes. And in the smallest box, we're talking about the providing cures or care to those who already have the condition. The bulk of our efforts, the bulk of our energy is often in the American kind of experience focused in on this bottom right kind of box, right? If we judge by the amount of resources that are spent. But that's only about 5% of a population, of any given kind of population that might be experiencing a condition. Again, the percentages vary depending on the condition itself, but let's say, for example, in this hypothetical, that a small percentage of the population actually has a condition, a sickness. What does that mean for what we should be doing across the continuum? As we zoom out, the question is, well, how are we focusing on the population at risk and investing in prevention? And then more broadly than that, the biggest box, how do we promote the health of the population through a variety of non-clinical interventions, public health interventions, including things we're doing in the social sector and economics and in policy. The challenge, of course, is that the vast majority of our resources in the US have been spent in the bottom right, with relatively anemic investments in prevention and health promotion, which is generally the purview of public health. And that imbalance, I think, is a lot of what I was speaking to before that leads to that a lot of scholars and a lot of practitioners kind of speak to as the challenge right now but to explain why we're having such poor outcomes. Public health, well, there's a lot of ways to kind of describe it. I provided a definition from a textbook, but I also wanted to share a definition that the industry itself, the field, has put out. The CDC put out this, and again, just using emojis to check if you're still there. If I put you all asleep, let me know with emojis if you've seen this, the 10 essential public health services. And if you haven't, that's fine. Okay, great. Plus minus, wonderful. So this is from the CDC. It's an updated rubric to be able to communicate the essential public health services. And what happened in the past few years when this was updated by the CDC was the centering of equity in all of the essential public health services, which, as you can see here, provide a framework for public health to protect and promote the health of all people, to work on to work across the boxes over here. So public health really cares about not just the big box and the second kind of box here, but it also has implications for and often supports and enables the work in care and cure as well. So public health really is the holistic, is all the boxes here, with a primary emphasis on the upper left, whereas healthcare is in the bottom right. And so to be able to do that, these essential services, here we go, provide a framework for how public health, in governmental public health specifically, kind of see its role. So there are a variety of activities. As a high level, you can see a lot of it is focused for public health on assessment, policy development based on those assessments, and then assurance of access, assurance of resources to the essential resources for health, to be able to ensure that we're improving outcomes across the board. That cycle is, as you can see, going around and around, and each of those specific activities in the 10 essential public health services is meant to support, with a focus on equity, how to advance public health. So let's talk now about something I've alluded to, which is the tensions between public health. If we understand public health and healthcare definitionally, now what are the tensions that traditionally exist? This slide is actually from our friends up north in Canada, who have done a lot of wonderful thinking over the years about the relationship between public health and healthcare, and have approached, from a policy perspective, ways to resolve the tensions between public health and healthcare very differently than we have in the US. And it's part of the reason that Canada actually has the outcomes that they have compared to the US. In this table, you can see on the left the various characteristics of public health, and when it comes to delivery, when it comes to targeting kind of who receives services, when it comes to objectives, services offered, and so on. And you can see the contrast between how public health approaches these characteristics versus how the healthcare system does. Some of this is actually really important to look at because of the concrete implications, not just academically, but really concretely on the ground, including in some of the projects you're working on. And I wonder to what extent, a table like this is something that can be applied to each of your reporting projects to be able to understand the tensions that are oftentimes implicit or hiding under the surface within the kind of healthcare and public health ecosystems among the stakeholders that you're interviewing and reporting on in this work. Because sometimes what's under the surface right now in terms of public health and healthcare reveals a lot of the reasons that we may have poor outcomes. Those often don't get interrogated because we don't have common literacy around the role of public health and healthcare and these tensions. So for example, I'm trying to remember if one of you can remind me one of your projects. There's I forget there's a project that I'll come back to maybe in the Q&A. We can come back to the slide and kind of try it out. But in the interest of time, I'll invite us to come back to this in the Q&A and try to apply this to your reporting projects. There's not just tensions, but there's also a lot of commonalities between healthcare and public health as well. On the bottom left over here, you can see some of the commonalities there, where public health and healthcare actually have a lot of opportunities to work together to be able to improve the control of diseases. I mean, the pandemic was a perfect example of the ways in which public health and healthcare were forced to come together and repair some of the decoupling that's happened over the past several decades to be able to improve response to COVID. There's also ways in which public health and clinical medicine work together to ensure that there's high quality of care, as well as to guide research and ethics, and finally provide kind of training and materials. One other kind of concrete example of what this means when we think about the commonalities is, of course, what we're seeing from our friends at Common Health Coalition. Right? When we're thinking about the commonalities of healthcare and public health, we know that as the pandemic taught us, we need to figure out ways to move from just to take the lessons of the pandemic and really start to bridge the divide between healthcare and public health so that we don't just work in parallel any longer, but work more hand in hand. And so this is part of why the Common Health Coalition for me is such an important and pivotal, and I think historic kind of moment right now to be able to help bridge these divides and to serve as a neutral convener, as a megaphone, and also to kind of drive action. It's part of the reason that in the commonalities kind of that Venn diagram that I show you right now, why the approach that the Common Health Coalition is taking to improve coordination, to to ensure coordination around preparedness, to provide real-time disease detection, and to be able to exchange data is so relevant because these are foundational competencies that allow for public health and healthcare in that Venn diagram to work together seamlessly. And you can see a lot of examples that are coming about. And so when it comes to resources, as I'm sure you've already seen in the first meeting, and I hope you see throughout the rest of the fellowship, the Common Health Coalition, Chelsea and Dave and the leadership team at Common Health Coalition, the 5 steering committee members, the 100 members plus that have joined since then, all serve as a resource database, I would say, for each of you to be able to think about how to inform your stories, not just the projects you're working on now, but for years to come. These serve as kind of your resources and your stakeholders that you can go to as experts to be able to understand how to inform better reporting on public health and healthcare. I'm going to pause here, I think, because there's many other things I want to share, including how to bring this into storytelling in this work and many other things that I'd love to talk to you guys about. But at least in terms of my charge, as I understood it, which is to provide a one-on-one on healthcare and public health and what I think the opportunities are for you as we get to the Q&A. I wanted to at least share that and see if that resonates. Elliot, is that helpful?
Yeah, that's great. And thank you so much for your insights and also for your work with HealthBegins. A reminder to our audience, you can share questions in the chat or use the Q&A function at the bottom of your screen. We've already gotten a few questions, so if that's okay with you, Dr. Manchanda, I'll ask a few of those questions now.
Yeah, let's jump in.
So we had 2 people actually ask, including one of our fellows, ask about avoidable deaths. We've heard so much from the new administration on spending versus outcomes, and they're curious if avoidable deaths includes deaths from car crashes and guns.
Yes. So avoidable deaths. One way to think about avoidable deaths, especially if we come back to that image that I shared before about prevention, right? Let me just pull that up because this is where these frameworks become helpful for folks like myself and in practice and policymaking advocacy, but hopefully for reporting as well. Let me go and share screen and see if I can pull it up again here. Oh, that's not the right slide. Let me find the right slide here. Okay, let's go back up to this basic one, right?
And
So
I'm not seeing your screen,
I'm
Dr.
sorry, that's the wrong
Manchanda.
screen. Wait. Can you see my screen now?
Yes.
Okay, lovely. So avoidable deaths it's a great question, and to kind of answer it, I want to ground us in this. Avoidable deaths really speak to a lot of the populations at risk, and so you mentioned kind of gun violence, car crashes. Absolutely. If you're driving in a car, right, and you're driving a car on a road that is unsafe, that has poor lighting, that has poor design in terms of speed traps or bends that with guardrails aren't present, et cetera. Or there's intersections where the design increases risk for the population of drivers, right, or pedestrians or others who use the same roads. By definition, we're talking about a population at risk, and the question is, how do we prevent those avoidable deaths? And the work of public health, as well as, of course, partners in transportation and other relevant partners for that population, in this case, car drivers, are all thinking about ways to be able to prevent deaths. And so one of the key examples of a public health intervention that came in from a very broad coalition many decades ago was, of course, the work led by consumer advocates, including folks like Ralph Nader and others, who pushed for more safety, right, in the manufacturing of cars, as well as the use of kind of seatbelts, et cetera. So public health is all about being able to identify populations at risk in order and intervening with broad interventions and in deep partnerships with many partners, including those, but not limited to those in healthcare, to be able to decrease avoidable deaths. Gun violence, same thing. We know that there are obvious risk factors that put people in harm's way, and that increases the risk of an avoidable death. And so gun violence is absolutely a pertinent question for public health and for healthcare, and of course, more broadly for policymakers. I think there was a first part of that question that I may have missed, but at least wanted to answer that. Absolutely is the answer to the second part of the question.
That's great. Thank you. Can you talk to us about some of the infrastructure that must exist, the MOUs, data sharing agreements, some of these things that happen behind the scenes in order to ease some of the tension between public health and healthcare delivery? And how can journalists find or learn about these important tools through their sources? What questions should they be asking up front, both, this for our fellows and also for any other public health journalists on the call?
Yeah, absolutely. Well, first, let me ask if I think one of my friends, Chelsea, is on the line as well. Is Chelsea, are you from Common Health Coalition here? I think Chelsea, you are. So I'm going to ask us to tag team here because Chelsea's, as managing director for the Common Health Coalition, probably has a wonderful list of kind of resources at the ready to be able to put into the chat related to infrastructure. And I think particularly for what Common Health Coalition is doing around the care kind of work. Um, and thanks, Chelsea. Yeah, feel free to drop resources. Thank you. And so I think there are resources to be able to understand the importance of having data sharing agreements in place between not just between healthcare entities. That's its first kind of challenge. There's oftentimes there are clinical interventions just in the healthcare ecosystem that go unaddressed or or inefficiently addressed because we just don't have the data sharing in place between providers of healthcare, let alone kind of intersecting with public health. So, for example, if you are in any given community and you go to a clinic, there may not be an infrastructure in place to have your clinic be able to draw down information from another hospital that you went to down the road or from another health plan down the road as well to be able to understand right away, what your needs are and update that data rather than have to ask you to repeat yourself yet again to gather all the intakes. In healthcare itself, we have a lot of fragmentation still. And so there are one important resource to understand just in the healthcare ecosystem, the work that's being taken place to improve the exchange of data and the sharing of data within healthcare is the work of what are called health information exchanges or HIEs. So health information exchanges have proven to be a really effective vehicle for policymakers, especially those in healthcare and public health, to be able to improve the data infrastructure just to communicate information more clearly within the healthcare industry. The reason I share that is because that health information exchange work, and I'm happy to find, thank you, Chelsea, yeah. So the health information exchange kind of work and the various, the organizations that support them, there's an organization called Civitas, I'll find the link and put it in the chat. There's an association of HIEs across the country. That work is vital to what I would call health equity infrastructure, because that infrastructure for sharing data within the healthcare ecosystem is allowing for the bridging of that database, that lake of data, as some might call it, if they want to get really wonky, the data lake, right, that exists in healthcare, to then start to interface with public health data sets as well. And so in addition to having bilateral data sharing agreements between, say, a hospital or a hospital association and the local public health department, which is vitally important, there's also questions about how to take the infrastructure of information exchanges like the HIEs and connect those healthcare data lakes, right, to the public health data lakes that are out there so that these bodies of water, so to speak, the bodies of data can start to interact with each other securely, confidentially, with security provisions and privacy provisions in place, but to make sure that we're moving past just a binary type of dyadic relationship where it's like, okay, each healthcare system has to create their own kind of data sharing agreement with the public health department. That would get crazy, right? So we need some sort of integrating function, and that's what HIEs represent to a large degree. And public health has its own kind of wonderful efforts, especially spurred by the pandemic, to start to ramp up a lot of the public health data sets as well, and the information exchanges that are happening in the public health space. So
Great. I think
there's a lot there. I don't know if I'm over answering or just answering it right.
No, that's great. And we have time, I believe, for one more question. Someone asked, do the cost of electronic health records implementation figure into healthcare costs?
They do. And so a lot of those costs were initially, yes is a short answer. What happened about 14, 15 years ago, coincident with the kind of the passage of the Affordable Care Act and what was known as the High-Tech Act, there was a lot of efforts that were put in by the federal government at that point to be able to modernize healthcare, including the use of the electronic health records. And that's been ongoing work for many decades, but especially accelerated in the past 15 years. And so the costs are included in the cost of delivery for healthcare, but those costs have been subsidized and have been standard, like the kind of implementations, the standards have been put forward by government to make sure that at least when healthcare is spending money on using electronic health records or other kind of data systems, that they're doing so in concert with the federal standards that are out there. And that's why it's so important for us to not just say yes to the first answer, which is the cost of EHR, yes, are part of healthcare delivery. But secondly, a big question is to what's the role of government to be able to ensure that those costs are subsidized where necessary to be able to spur adoption, right, of electronic health records, but also, as we've seen, to make sure that all the vendors that people use are aligned using the same data standards and frameworks.
Wonderful. Actually, I do want to end with maybe one piece here. If you could offer one piece of advice right now to journalists, to storytellers
Yeah.
covering this right now, covering public health, what would you say? What would you offer?
Well, so I appreciate the question, and I'd be remiss if I didn't say, like, right now there's a real heightened, one of the most heightened degrees of fear and uncertainty and chaos right now in healthcare and public health because of what we're seeing through executive branch actions right now, through federal um, um, policy changes right now, as well as executive orders. And that chaos and confusion right now, one thing I communicate is that actually is not just the threat of harm that people are worried about, it's actually the harm that is taking place. And so to the extent that you're able to work with those in healthcare and public health to be able to ask them, to what extent is this actually impeding the pursuit of healthcare, public health, or the shared agenda for the two? To what extent is this impeding the ability for healthcare and public health to work together? And ask them to share stories. You'd I think really tap into a lot of the ability for healthcare and public health to give voice to the concerns, as well as to bear witness to, as they want to do, right, to the harms that are taking place right now for even just some of the things that have happened in the past several weeks. The reason that's important is not because of a partisan kind of issue, but because of the charge of healthcare and public health, which is to protect and promote, right, health. And right now, there are a lot of folks in healthcare and public health who are unsure about what they can do in this moment because of the flurry and the chaotic and confusing kind of amount of information that's out there. Helping healthcare and public health understand policy threats and asking them to be able to bear witness to talk about the harms of those things is a major kind of step forward. One of the things, just to concretely kind of land on, is one thing we're doing in this moment with HealthBegins and a number of kind of partners is to create a tracker to help those in healthcare and public health just track the various policies that have been put out, both the executive branch and increasingly by Congress and this administration, to be able to understand the policy environment and understand potential threats to public health and healthcare for those. So we're putting out a policy tracker and helping inform healthcare and public health practitioners. That would be a welcome opportunity to at some point collaborate potentially with public health reporters, such as everybody on this line, to think about how those policy threats, to understand those policy threats, and then connect people to the resources to understand how to better respond. So I think this moment is an existential kind of moment for a lot of people in healthcare and public health. And the more that we can, that you can reach out to healthcare practitioners in public health and just ask them, how is this harming your patients, your communities right now? What are you worried about? And can you share stories so we can kind of bear witness to this, I think, is the first step.
That's incredibly helpful, Dr. Manchanda. Thank you so much, and to our audience for your questions. We'll share a link to the recording soon, along with the resources shared during the briefing, including the ones in the chat. The National Press Club Journalism Institute is proud to produce programs like this at no cost to journalists across the U.S., with the mission of powering strong journalism in the public interest, especially as we're talking about these collaborations. If you'd like to support us in this work, we hope you'll consider making a donation today, and we'll drop that link in the chat. Please spare a few moments, if you can, to fill out our survey to tell us how we did today, and also help us improve our programming, offer suggestions. We hope you'll join us for the next program in this series on March 25th, which will focus on covering public health policy in the current political landscape, which I know came up today. For that, we'll be joined by Julie Rovner, Chief Washington Correspondent at KFF Health News. Thank you for joining us for this public portion of the program, and we hope you all have a great rest of your day. Thank you.
Elliot, can I say thank you to you guys? And also I put a question into the chat. Just want to draw everybody's eyes to that for a second, that you're welcome to follow up with me offline or Chelsea about as well. Because I'm actually as curious about how we can be supportive in the public health and healthcare space to the reporting to the reporters about what you actually need right now to actually report on this moment too. So please let us know and feel free to follow up. Thanks, guys.